Okay, I think we'll go ahead and get started now. We've got really good presentation today, really good amount of information. So I want to go ahead and get started at right on time, and hopefully we've got a good crowd. Very much appreciate everyone participating. Certainly our speakers, also the folks who've dialed in. I think we've got a really interesting topic. I know it's a place, health systems I've worked. It's been a hugely important topic for us. So I'm David Fletcher. For those of you who don't know me, I am the System Director of Telemedicine at Vandalia Health System in West Virginia, and I've been a proud member of the Telehealth Collaborative here with West Health and a lot of the folks on this call for several years now, and really enjoyed getting to meet everybody and learning from them. And I think today is a great example of that. So we've got a great group. We've got Dr. Kevin Curtis, Ellen Flaherty, and Katie Darling from Dartmouth today to talk about telehealth and its role in fall prevention programs. And I know many hospital systems I've worked with have really struggled with this and been looking for kind of technological solutions, both to prevent falls, but also to do it kind of in a cost-effective manner. And so I think we've got a really interesting presentation today to talk about it. And then after the initial presentation from the folks from Dartmouth, we've got be joined by Dr. Veronica Rivera from Mount Sinai, and to kind of give a little bit of, the kind of practicing physician to talk a little bit about, kind of how this type of program might work in a kind of day-to-day setting. So really excited to kind of hear best practices. I think it's really one of the strong suits of this collaborative, and one of the things that I've really gotten a lot of value out of. So excited to hear about it. And so without further ado, I'll go ahead and sorry, I should mention Linda DeSherry will be moderating the session, and she's from Medically Home. I think many of us know her from her work there. So I'll go ahead and hand it over to our presenters, and so we can hear some of this great information. Thank you.
Hi, everybody. Kevin Curtis here. I'm an emergency medicine physician, been doing that for a little over 25 years and been at Dartmouth Health for 22 of those. And I'm also the medical director of Connected Care, our Center for Telehealth. So thanks so much for joining. I'm going to give just a 3 or 4 minute big picture of telehealth at Dartmouth, and then I'll hand it over to Dr. Flaherty to talk about the Center for Aging and the Falls Prevention Program. So a little bit about Dartmouth Health. We are located in New Hampshire and Vermont, so a very rural region, and the health system includes the most rural academic medical center in the country. So as a result, our population in our region, people have long distances to specialty care. And that's, of course, if they can find transportation, if they can get a half day or a full day off from work to make it to the appointment, if they can get childcare. And even on top of that, particularly at the medical center, we have significant capacity challenges, both on the inpatient and on the outpatient side. So in response to that, now 12 years ago, we formed Connected Care, or Center for Telehealth. And really, the mission continues to be, how do we use telehealth to help deliver outstanding care to the region, independent of patient location? And really, our program is pretty agnostic to whether a hospital or a clinic is in our health system or not. Our focus is largely on rural healthcare, but not exclusively. And a secondary goal of all we do is to try to keep care local whenever we can. That, as you know, that's good for patients and families and caregivers. That's good for the community. That's good for the local rural health system in those locations, in the rural hospitals that are always challenged to stay open and keep the lights on. And it also is helpful to the academic medical center as we preserve capacity there. Here are our current connected care telehealth services. Just real quickly, we have a tele-emergency hub at the Academic Medical Center that operates 24/7 to 12 EDs in Northern New England. We have a busy tele-neuro-stroke service doing about 450 consults a month. We have a tele-ICU hub to 105 beds. We have tele-ICN for neonatal emergencies. We have a lot of scheduled outpatient virtual visits. We have a telepharmacy program doing about 100,000 orders a month, emergency telepsychiatry, central monitoring of 200-ish cardiac beds, and additional inpatient specialties. And this is just a map of Northern New England and a little bit more showing the bricks and mortar locations, primarily hospitals, where our connected care services operate and partner. And you can see that essentially every hospital in New Hampshire and Vermont has one of our services, and the majority have 5 or 6. The one other thing that I'll say is we are pretty diligent about not just measuring volumes of services, but really measuring impact. So impact on patients and families and caregivers, impact on bedside clinicians, impact on cost, impact on access and equity, and impact on meaningful health outcomes. So with that, I will hand the presentation over to Dr. Flaherty.
Thanks so much, Kevin, and thank you, everyone, for inviting me. I am Ellen Flaherty. I am the Vice President for the Geriatric Center of Excellence at Dartmouth Health, and I am a practicing geriatric nurse practitioner, and I've been at Dartmouth for about 15 years now, spending most of my career in New York City, starting out at Mount Sinai, actually, and then at NYU. So happy to be here. I have no conflicts, no disclosures. So first, I want to talk about the Geriatric Center of Excellence to provide some context for this work. So the center, when we think of Dartmouth Health, that's the umbrella over our, as Kevin pointed out, our large critical access level 1 trauma center in Lebanon, our flagship hospital, and then our affiliates, which are 6 critical access hospitals in Vermont and New Hampshire, and also ambulatory care in the South, as well as here in Lebanon. And so the goal of the center is really to provide a structure that supports and aligns everything geriatrics across our system. Typical of most centers, the 4 pillars of clinical care, education, research, and policy, and the 4 horizontal arrows represent IHI's model, and the top arrow speaks to the 4M care. So we are a age-friendly health system and have been recognized by the Institute for Healthcare Improvement since 2019. So when we think about 4M care, which many of you know, is a framework that was developed by Terry Fulmer from the John A. Hartford Foundation and implemented through IHI. And it focuses on what we call 4 M's: mobility, what matters, medication, and mentation. And when we think about mobility, we think about a number of things for sure, but that's really where falls prevention and exercise falls in the context of our age-friendly health system. Part of this work was initiated when we received actually our first HRSA grant, which was back in 2007. This mechanism of funding used to be called the Geriatric Education Centers. It is now our GWEP, which is the Geriatric Workforce Enhancement Program. We were just refunded in July for the next 5 years, and there are 44 GWEPs throughout the country. And a big part of the GWEPS is to think about age-friendly health systems and the 4 Ms. So I'll keep going back to that. We developed a model here at Dartmouth that focuses on coaching primary care practices around the implementation of Medicare reimbursable services. Part of that is the evidence behind these services. So the annual wellness visit, transitional care management, chronic care management, and advanced care planning. And while these codes exist, and again, demonstrate good evidence-based care for older adults, some of them are quite challenging to implement in a primary care practice. So we have developed toolkits and a lot of coaching with a methodology around learning collaboratives. So we've been doing that a fair amount in the 3 northern New England states, but also in partnership with other GWEPs throughout the country. Our Falls work, while it was funded by the GWEP as well, was really, I would say, supported in a very large way by our Administration for Community Living grants. The first one in 2015 focused on building statewide capacity for evidence-based falls prevention programs with a goal of significantly increasing the number of older adults and disabled older adults with Parkinson's to participate in an evidence-based falls prevention program. And I'll talk about those programs in a minute. The next grant really focused on developing the New Hampshire Falls Prevention Network Hub and to develop this regional Tai Chi Quan Moving for Better Balance training center, which we have here. And the last grant that we got in 2020 really focused on pathways and creating referral pathways between healthcare and community-based organizations. Many of you know that when you think of primary care and community-based partners, it's they pretty much speak different languages, and it is quite the challenge to be able to do that. What we did was we partnered actually with 2 GWEPs. We partnered with the Bay State GWEP and the Rhode Island GWEP to help them to bridge that gap between primary care and community-based organizations. And some of that actually was done through telehealth referrals, back and forth between the community-based organizations that would actually do the screening and would also do more in-depth balance assessments and actually host the evidence-based programs. And we did this through what we call the Dartmouth Falls Prevention Training Center. So I talked a little bit about this, about building the capacity for a matter of balance in Tai Chi Quan. These are the 2 evidence-based programs that we've implemented in a much larger scale across New Hampshire and subsequently in Massachusetts and in Rhode Island with our partnerships with the other GWEPs. A Matter of Balance is a program that focuses on reducing the fear of falling. What we know is that fear of falling leads to decreased activity, strength, increased falls. And the evidence is that as somebody increases their activity level, that they will have a decrease in fear of falling and ultimately continue their mobility and resulting in less falls. The program is 8 2-hour sessions. Each session sets goals for increasing activity. And the beauty of A Matter of Balance is that you can enroll relatively frail older adults in this program. It does not require a lot of physical activity. There is one physical component to it. And unfortunately, this was not an approved program virtually when COVID hit. Some of the other programs, and I'll talk about the Tai Chi, immediately converted to be able to offer these programs remote. A Matter of Balance did not. They have subsequently done that, which is great, as Kevin talked about, being in our rural area, trying to get people to come into the centers has been challenging. So Tai Chi Quan, Moving for Better Balance, has I would say, probably the most robust evidence for Parkinson's patients who we know have a lot, not only are at risk for falls, but obviously have experienced a lot of falls. It was developed by Dr. Fuzhong Li in Oregon, and it combines classic Tai Chi Quan and what we call postural control science. As I said, it really decreases falls 58% in individuals 65 and over, and 67% in people with Parkinson's. And people have 75% fewer injurious falls. One of the things that when we started the falls program was to think about how we could implement kind of mass screening across primary care. So we implemented asking these three falls risk questions. Have you fallen more than once? Have you injured yourself as a result of a fall? Or do you have self-perceived difficulty with mobility, or are you concerned about your falls? So patient would come into primary care. This would be part of the questionnaire they would fill out, just as pain, vital signs. The medical assistants put these data into Epic for us. So here are some data about our primary care screening, which was pretty successful. And we added these questions to the emergency department for patients that were being discharged. So all patients 70 and over who were being discharged were asked the three questions. And as you can see, a lot of people screen positive for falls, and we can talk about that in a minute as well. I will show you in a subsequent slide, but what we were able to do through our EMR, because our Aging Resource Center is part of our network, and that is where the falls prevention program sits, we were able to create an automatic referral based on a patient screening positive for any one of those questions. And a referral automatically then comes into our Aging Resource Center. The Aging Resource Center then reaches out to the individual and initially invites them to come to the center for a balance assessment, further balance screening, or to participate in a virtual balance screening. That all started in COVID, and actually more than half of the people that agree for additional balance screening actually are doing it remotely now. What we've been able to do also in our EMR is to create a referral to the Aging Resource Center. And this is predominantly for primary care. When a patient screens positive, we do not have an automatic mechanism there. That's only in the ED. So providers, medical assistants, nurses, this is not necessarily an order, can make a referral to the Aging Resource Center. As you see, one of the menu items there is falls prevention. And those are some of the other services that we provide that folks can refer to as well. So we developed this concept of what we call balance days. And pre-COVID, these were open days that we would advertise where folks could come to the center to have their balance assessed. Part of that was not only identifying those at risk, but using motivational interviewing skills to connect people to the evidence-based community programs that we had already developed, A Matter of Balance and the Tai Chi Quan. What we find is that when older adults come to a balance day, they come to the center or participate virtually. Not only do we have a much greater chance, of course, of enrolling them in a program, but we have a much less recidivism rate through what happens at that balance day in terms of the motivational interviewing. We have promotional tear-off sheets that make, obviously, that easier to connect to our programs. We distribute them in primary care and the emergency department. So this is the front of the tear-off sheet, and this is the back of the tear-off sheet. And this, again, these were all distributed. This was when we were exclusively doing in person. Now, as I mentioned before, so much of what we do is virtual. Just one last comment. When COVID hit and we moved to remote screening, of course, one of the concerns was safety. So we actually had a kind of safety assessment that we called people on the phone and asked them some very specific questions about their environment, where they would be tested, who was in the house with them, et cetera, to ensure safety doing this virtually. Thank you. And I will turn it back over to my colleague, Katie.
Hi, everyone. So I'm Katie Darling, the Director of Operations for our Center of Connected Care, Telehealth at Dartmouth Health. I'm really here just to show some data regarding our patient population 65 and older. In the beginning of pandemic, just like everyone, we're all kind of thrown into using telemedicine. It was a new system, and we've seen such an improvement in the use for our aging population. So really just here to share some of that data with you today. In 2020, as you see, for all of the telemedicine visits provided to patients 65 and older, in the year 2020, 60% of those were delivered by audio only. As we fast forward to the end of 2023, that has changed drastically, that only 33% are audio only. So we've seen a huge shift in the video and audio connections over the years. In addition to that, we do calculate failure rates. So we look at a telemedicine visit that was scheduled as an audio and video visit, but ultimately was delivered by audio only due to some kind of technical or broadband failure. So in 2020, when the pandemic started, our failure rates for ages 65 and older were over 23%, which is a pretty high number for failure rates. So we continued working on, education over the years and working with Ellen's group and the Aging Center to really help improve this and change the way we were educating our patients for video visits. As you can see now, from January to July of this year, that failure rate is only 9%. And if you remember with the last slide, those video visits have drastically increased at the same time. So we're really happy to see this rate go down. And then this is some of the satisfaction survey results that we have. So one thing is, we use Press-Ganey to send out surveys to all of our patients. So again, 65 and older are the data that we collected here. So that rate of talking to your provider virtually in 2020 was down to 78% satisfaction. Now we see that swing up to 86%. For our virtual urgent care service that we had, that overall satisfaction, 88% are satisfied, 87% got the outcome they expected. So we continue to see satisfaction grow as well. So we're just, really excited about the growth of, the video visit use. The patients are enjoying it and really liking this additional way to receive their healthcare when needed.
All right. That was a wonderful presentation where we got to hear about a really robust falls program at an institution that has a large infrastructure for telemedicine. and how they are doing all aspects of that falls program. It looks like referrals and screenings done, of course, in person, but also through telemedicine. So now we're going to start our panel portion. We have our three speakers have already introduced themselves. And I'm going to have everyone come on video. And I'm going to have Dr. Veronica Rivera introduce herself. And then we'll get started with the panel discussion.
Good afternoon, everyone. My name is Veronica Rivera. I'm an ambulatory geriatrician. I work in two different settings, an academic health system at Mount Sinai in New York City as an outpatient geriatrician and also the medical director for the Martha Stewart Center for Living. And I also still see patients in a healthcare system called the Institute for Family Health, which is a network of federally qualified health centers.
And I should probably introduce myself a little bit more. I'm Linda DeSherry. I am also a geriatrician, and I have spent my whole career in the home-based medical care space, home-based primary care, and the last number of years pretty much exclusively focusing on hospital at home and acute care in the home. All right, so I have a couple questions to present to our panelists. And then those of you who are participants, audience members, please start putting questions in the Q&A because we're going to have time for your questions at the end. Maybe I'll start with Kevin. How would you suggest someone go about marshaling institutional support if they wanted to implement a fall prevention program at their health system?
Yeah, it's a great question. And certainly in connected care, institutional approval is something that we have thought a lot and done a lot about over the years. So I guess I'll give our general approach in our different connected care service lines. And then if Dr. Flaherty wants to give an example how it specifically applies to the falls prevention program. So when we are designing a new program or implementing it or evaluating it, we kind of think about two different buckets. And this is just our approach. One is we're still believers in the IHI, and you heard several things from IHI, from Ellen, but what has started out as the triple aim probably 15 years ago, and maybe more, and then has become the quadruple aim and the quintuple aim. So we think about all the time, how will the service deliver on ideally all of those or most of those? So just as a reminder, how does it enhance the patient, family, and caregiver experience? How does it help bedside clinicians, particularly since we're reaching so far in the region? How does it improve access and equity in our rural region? How is it either cost tolerable or potentially a financial win-win, particularly for example, small critical access hospitals or for the people participating? And then finally, what are the true health outcome benefits? And I'll just give first, the other bucket we think about is how is the service either aligned with the health system strategy or addressing a key pain point? So that's kind of the other bucket, making sure that this aligns with what's going on or is causing challenges. And just a quick example. So for example, tele-ICU, which includes a lot of older adults, but includes others as well. You know, when we were designing that several years ago, we really said, how is it going to enhance the patient experience? Well, we'll keep more people close to home. How is it going to improve clinician experience? Well, we'll provide support to them. How will it improve access and equity? Well, you'll be able to get critical care services where you are. How will it improve cost? Well, it'll benefit the ROI of the local hospital by keeping care local. And then how do we impact meaningful outcomes? Well, people have shorter length of stay, et cetera. And it was also a pain point for our health system. How do we optimize all the beds in the region so that people can get the care they need in the location they need? So that's just kind of one example, but that's the approach that we took a decade ago and still kind of take, is quintuple aim plus how does it align with strategic direction of the system or the organization, and how does it help avoid particular current pain points? Ellen, I don't know if that resonates with the falls prevention program.
Yeah, I think you're absolutely right, Dr. Curtis. I think, you know, we say, how do you make it easy to do the right thing, right? So even when somebody is being discharged from the emergency department, that extra step of having the person make the referral versus the referral just happening, right? And then how do you use other components that are not part of the ED, not necessarily part of primary care? We're most fortunate here to have an institutionally funded aging resource center. But even when we have gone to other communities, senior centers, AAAs, a lot of them have falls prevention programs and are eager, absolutely eager to work with primary care and the emergency departments to recruit patients.
Veronica, I don't know if you have other thoughts on this question about getting institutional support for programs like this from your perspective.
Yeah, I agree with everything Kevin and Ellen have brought up already. I think one important thing another way to look at this is falls is a quality metric, right? That many of our healthcare institutions are looking at and monitoring as well. And so it is a HEDIS measure looked at by NCQA, PCMH certifications. Also, if you're doing work like at Dartmouth in the age-friendly health system space, I think it's really important to know your data, know what's happening locally at your institution, the screening rates, but then really seeing what is happening also nationally in terms of real significant outcomes and consequences for this metric. I think hospitalization utilization, ER utilization, mortality rates, all connected to falls, can really help garner that institutional support. Of course, funding helps too. If you have programs like the GWEP that can also bring attention to this. But even without that present, I think there should be a lot of motivation for health systems to really look at this as a quality metric that needs to be tracked, measured, and really look at outcomes to sort of show that the interventions you're putting into place are having benefit for your patients. And it also helps to have those stories. I think we all have those very powerful stories of patients and loved ones who have had real significant consequences from falls that I think also really are very meaningful.
I think also just to add to that is, for us, we needed to build capacity for the programs, right? Because we heard from many clinicians about, yeah, I can screen, but what do I do with that information? If I don't have a program to refer somebody to, it almost seems unethical to be screening when I can't do anything about it. So that was a big piece of it, to build capacity for the programs, and then to be able to offer them remote has really been tremendous.
Ellen, I have another question for you. You shared, and I saw in the Q&A, someone asked for the exact questions that you use. Do you believe those risk screening tools are mature enough to be ready for out of the box, or do they really need to be tweaked by each institution to make them fit their populations?
Yeah, I think they are ready to go out of the box, evidence-based. There is a lot of work that's constantly being done, focusing on the CDC steady requirements and implementation. Actually, there have been some new guidelines, but those three questions, I think, really get to identifying people who even have are on the lower falls risk end, right? But so it captures a lot of people which I think is certainly better. And then moving them to the next level of doing more intensive balance assessments, then that's when we can, risk stratify and then do the motivational interviewing, especially when somebody, falls into a much higher risk category.
And I love that you're using the same screening questions. It seems like across your institution, at least we heard the ED and primary care. So there was like, this is what we do, kind of how we're doing it. I don't know, Katie, about the operationalizing all of those across. Was that something that was difficult within the institution to get the same questions everywhere?
I would probably put that back to Ellen. I'm not so much in the geriatric space, but it did look like an EDH build through our Epic system. So likely when you can put it on for one department, you can easily attach it to others to kind of use it system wide and throughout all of our system members as well. So not just in the Lebanon campus, but throughout the system, which is great.
Yeah.
Yeah,
That makes sense.
and I think the positive thing is that once it's built, right, the system doesn't fail, right? The system works great. Back to workforce, right? So many institutions faced such a shortage of medical assistants, right? So what's happening with that paper that the patient filled out in the waiting room, right? Is that actually getting into the record? So I think that's probably one of our biggest challenges, and trying to think about, again, that automatic referral that we kind of, as I say, jerry-rigged from the ED, where the referrals actually come into my in-basket. And then we have a team that jumps in and manages that. But it was a workaround, and we've been doing that for 5 years, and it's working. So I think adaptability, and being able to think of different ways that, okay, let's do a huge Epic build, which, as we all know, is quite challenging. So that's how we kind of came up with some workarounds.
Yeah, Veronica, what do you think about the screening tools? Are these tools pretty ready to go out of the box, or are they different at Mount Sinai, for example?
I also was going to reference the CDC and the study algorithm, as we are actually at Mount Sinai also using similar screening questions, but now working on the after the screen is positive and sort of standardizing the assessment and the interventions for providers. And there's a wealth of resources, I think, on the CDC website related to falls, in addition to the study algorithm, just some data and a lot of a summary of all the interventions and evidence behind those. So I do think it's a great resource, but we are also using similar questions at our institution.
Veronica, I have another question for you. How receptive do you think your patients would be to a program like this? And how would you frame the discussion?
Yeah, great question. I love when Ellen was speaking about the motivational interviewing and the sort of getting the buy-in from patients. I think every patient is different, and sort of meeting them where they are. I think in general, for those who need a little bit more convincing, I think really presenting falls as a real medical condition that needs attention, just like their diabetes and their high blood pressure, as it can have real significant consequences for them. I think patients really appreciate when you talk about maintaining independence and living in the community, preventing injury, preventing hospitalizations, and anything that can help improve socialization and reducing isolation and loneliness, I think are all potential selling points. I think a lot of patients are looking for real advice on exercise and falls prevention, and they do see with aging that this is something they want to work on. But yeah, if they're not as motivated, I think sort of doing that motivational interviewing and getting them to buy in. I think the telehealth component is wonderful. I think so much of what's challenging is getting patients to commit to coming in. If it's a program that happens weekly over 2 months or longer, that can be a barrier. But if you are able to make sure they have good access to telehealth, of course, the connectivity and the devices and the support they need, it can be a real great option for people who are want the services or the intervention, but are not able to come in as frequently.
Ellen, we heard both from you and from Katie about, first of all, the telehealth has a great uptick and really great connection to patients. You also talked about once you get them, then they're more likely to do that next step of doing one of these programs. Do you have any other comments on the receptivity to the programs that you wanted to bring up still?
Sure. While the TJ Kwan Moving for Better Balance has the highest level of evidence, it's also has the highest dropout rate. And that's because of the intense nature of the participation. So it's twice a week, right? For 24 weeks. That's the initial program. And what we know is that after that 24 weeks, what we start to see is the drop off in the benefit. So it really is a program that people, to get the full benefit, pretty much need to participate for life. So, which is great. I mean, there's a lot of connectivity there. And pre-COVID, when all of our classes were in person, there was a huge component of companionship and people getting to see each other. And so as we start back with some of our in-person programs, that's certainly a benefit, but much, much harder to achieve full completion in terms of attendance with the Tai Chi. Not so much with a Matter of Balance, which is a much shorter program, but of course then the evidence is not that great. We have these two programs. We're actually starting another program called SAIL, which is another evidence-based program. And part of that was trying to attract people to come back into our center for just what I said, to really think about decreasing social isolation and getting people back together. I think when people stick with the program, we absolutely see this camaraderie, and that really helps people to continue in the programs. So a Matter of Balance, again, is for pretty much almost anybody, regardless of level of frailty or mobility. Tai Chi, yes, there are, participants that have walkers and already have obviously balance issues. But not everybody can do Tai Chi. So that's why we have both of those programs. We kind of see one as a feeder into the other. People finish a Matter of Balance, and we coach them to move into the Tai Chi Kwan.
I'm going to ask one more question before I turn to the questions that are in the Q&A. And maybe I start with Veronica again on this one. I want to just do a little step back here. What is the scope of the problem of preventable falls? And we're all bought into that. Dartmouth, you guys are making this great program. Veronica's doing this program. We're geriatricians, internists here doing this. But what about the visibility with other stakeholders? What have you seen, Veronica?
Yeah, I think this is a massive problem, and it is definitely a large in scope. I think, again, just some basic background that I also came across when preparing for today. We have in 2021 like 3 million ER visits alone in this country, just secondary to falls, and 1 million fall-related hospitalizations every year. And we're also seeing significant injuries, hip fractures, about 300,000 yearly from falls, also TBIs, traumatic brain injuries, et cetera. And so I think there are a lot of stakeholders who have interest in looking at this. Of course, one of our biggest stakeholders are patients and families. But really, I think thinking about all the healthcare utilization, whether it's your hospitals or emergency rooms, but you can even think about outside of the hospital and your academic health centers, your community partners. So use of physical therapy or TRAs, also home care services, and Medicaid funding is very interested in the independence for seniors. And so I think there's also probably a lot of community partners and relationships that we can continue to build, and a lot of stakeholders who do have interest. I think making those connections and working together to sort of highlight the importance of this work. Again, I think in your local institutions, going back to that, really knowing what's happening with your own patient population can really help bring attention to the issue at your sites.
Yeah, I mean, I think that it's, on the surface, some people want to understand this and know this, but it really is, still, I think there's some ageism and misconceptions about falls. And I think that plays a big role into not understanding that it's always that important to identify and help see what we can do to prevent. So. All right, I'm going to turn to the Q&A that's we got from the audience. So I'm going to read off some of those questions. Dr. Flaherty mentioned age-friendly falls prevention program. Is this program in collaboration with AARP network of age-friendly communities? Thanks. Oh, I see, Ellen, you might be already starting to type the answer. So
yeah, I started to type it, then I figured I'll just, yeah. So, yeah. So that's a great question. And when we think about creating age-friendly communities, certainly the AARP network is one of them. Unfortunately, Vermont and New Hampshire do not have a network, an AARP network, which considering they are two of the oldest states in the nation, but maybe we can influence and have something to do about that, certainly with our new GWAP for sure.
So does Tai Chi require an instructor? If so, where can one find one? Can the instructor be provided virtually, or must that be in person?
Yeah, so it absolutely requires a certified instructor. We're fortunate here that we have one of 5 master trainers who can then go and train others, and that's kind of the basis for our falls prevention program. I'm happy to, folks can contact me and I can give you the exact mechanism through Dr. Fuzang Lee to find instructors.
How replicable do you think this type of program would be in maybe a smaller or mid-sized health system? Maybe I'll start with Ellen, since you started this particular one.
I think when we look at, again, some of the smaller falls prevention programs in our rural communities, right, can really make a difference. So I think while we were able to, through our federal funding, develop a much more robust training program and a hub and how we track individuals. I actually think that it can be done in relatively easy in some smaller systems as well. And as it has been done too in our critical access hospitals. And now that there are so many programs that are offered remote, that really is a huge benefit, especially as we as our leaves start falling here and we start thinking about snow. Really having these remote programs has really been terrific.
Right, as you start to, you can do the screening at your local smaller and mid-sized health system, but the program that you might refer them to can be in a much bigger geography because of exactly like you described. Yeah. What kind of administrative structure? I mean, you mentioned all the referrals are coming through your Epic In Basket originally, or maybe still. What kind of administrative structure do you require if you're going to pilot a program like this?
Yeah. So right now, and again, we had obviously a team who was able to create this prevention program, but right now we have a 0.5 FTE somebody who sits in the center who does, again, responds to all the referrals that come in, makes all the phone calls, answers any of the emails that come in, and then actually does the screening. She also is conducting some classes. So it doesn't, I'm not saying that a 0.5 FTE is nothing, but in the context of a lot of other programs, and I think the benefit, right, of this for just a small FTE within the context, right? So we have a center where the lights are on and the phones are there, and so, but it doesn't take much for us at this point to run this program.
I see one more question that came in the Q&A. It's about Tai Chi being in person versus telehealth and the usefulness of both modalities.
Yeah, I mean, I think what I can share is that my husband participates, and so I at times will be, have it in my living room. And my husband is not tech savvy by any stretch of the imagination, and he somehow gets on and participates. And I think his confidence is much greater. He had not been somebody that was having frequent falls, but I think his confidence in terms of mobility and hiking and the things that he wants to do have really added that confidence to him to be able to continue to do that. And the more active he is, obviously, that has such an impact on everything from, isolation to, as you all know, keeping people mobile. And, that was one of course, our biggest concerns in COVID, right? At least here in New England, people had backyards they could walk around. In New York City, you guys suffered so much more, and it was even that much more difficult for people to maintain their physical mobility. But I think again, being able to provide these programs virtually has really helped so many people. So and has really, really we've been able to market the programs, which are all free, by the way, which is another wonderful thing for our participants, to a much broader audience throughout the 2 states. Yeah, Vermont, New Hampshire.
I'm going to ask one last question before we close it out, and I'd love to hear everyone's responses. How do we see programs like this evolving in the next 5 years? Ellen, you want to start? And
yeah,
Katie, if there's anything you want to add from the Dartmouth side?
Yeah, I mean, if we go back to the data that Katie presented, right? So look, we have come so far in terms of older adults and having older adults participate in everything from Zooming with their grandchild to Tai Chi to participating in a a telemedicine visit, and Katie and her team done such an incredible job like that, right? And working with our team around older adults and creating kind of laminated sheets and all the work that was done. I think that's the legacy that will continue. And it's not just for falls prevention, but so many other things. But I think that's, we've also busted a lot of myths about older adults not being able to get online. And for all of the, we would have Zoom coaching. And even now, for anybody who participates in any of our programs, they participate in a Zoom coaching session on the phone. And we have 99% success in terms of folks who want to get on, who couldn't get on, coaching, telephone coaching. Yeah, it's incredibly successful. So, of course, you know, the internet is another whole problem that we're certainly not going to solve today for sure. But that you know, becomes a barrier certainly where we live. But yeah.
And
Maybe
thank
a
you,
minute
Ellen.
left. Anyone want to? Yeah, Katie, go ahead.
I would just add to that. I think a key component was really the education and meeting the patient with the education they needed to be successful, whether it was the one-on-one coaching or when they were in the office, teaching them, downloading the apps before they leave. So it was really kind of helping to meet the patient with the education they needed to be successful.
Yeah, the only thing that I would add, again, at a bigger picture is that, you know, particularly on the outpatient side, as we all know, we had this unfortunate telehealth accelerator in the pandemic, and we all did, you know, hundreds of thousands of visits, and then it has hit some plateau, and now people are familiar with it. And now I think it's a great time to pause and really do redesign, get feedback, and see what is the 2.0, because even though it's been a little while, we still are at the fallout from the reactionary phase of the pandemic and telehealth acceleration. So now let's get more information. Let's see what we've learned. And now we have so much more engagement. We have identified some issues, but we should all be taking advantage of this redesign opportunity to say, what do we want it to look like? Which means not, you know, what do I want it to look like, but what are our patients, our families, our caregivers want it to look like? And let's redesign. So I think we really are at that key point where we have a responsibility to now implement what we've learned.
Thank you, everyone. Thank you, presenters and panelists, for a really wonderful, insightful discussion today. Before we wrap up, I just want to let everyone know the session is been recorded and it'll be available on demand on the CE4TA site. Our next webinar is in October, and we'll of course share more details in the coming days, so please stay tuned. So thank you very much.